Good evening, dear students. I am looking at the chat as well. Dr. Sachin, Solanki, Manish, Soumya. Yes, good evening. Namaste. So, today's session, as I understand, yes, Harish, good evening. So, today's session is basically trying to, okay, a lot of good evenings are coming now, and it won't be possible for me to greet you all. Wonderful. So let me try. Vakusa, Upasna, Anupam, Suryakant, Sachin, Chetan. Uh, a very warm welcome to you all. So as you understand, today's session is to kind of prepare yourself towards the INI-CET exam, and because the time is very limited with us. Before I start, I was just thinking about telling you that how I used to prepare for my PG entrance exam. It was year 2000. I had joined AIMS Delhi in 2001. So what I do is I start midnight, 12 midnight, and I'll be studying from 12 to 5 non-stop. And at 5 a.m. there used to be some trees around our house. Some birds will start chirping, and I'll switch off my lamp, table lamp, and sleep. So 12 to 5 daily, that was my schedule. And as the exams came closer, the schedule of 5 hours became 10 hours, 12 hours. I remember, like very near to the exam, it used to be 16 hours also per day. And in our times, like, we were very focused. Even you people are very focused, I believe. But for me, I had a table and a table lamp, and the area where the light was falling, I could see, like everything else was blurred. So my point is, you should be that kind of focused. And start with spending some 5 hours per day, increase it to 10 hours. And but don't over exhaust yourself, because sometimes what happens is exam is say 7 days ahead, and we are peaking around 3 days prior to that. Now, before the exam, those 3 days, you are doing nothing. You are exhausted. That should not happen. Means not, you should take a peak, but that peak should match with the exam day. Otherwise, those 3 days, you won't be doing nothing. You will be trying, but nothing will happen. So be careful about timing your energy levels and the way you push yourself. Okay, so when will Cerebellum Academy class 2 happen? See, these are all personal questions as such, and you can later communicate with me, but at the moment, let us focus upon the task at hand. So you see a diagram in front of you, which are the following arrow marked nerves, if injured, present with paradoxical breathing. What is paradoxical breathing? Paradoxical breathing means, say for example, one-sided phrenic nerve is not working and the other is normal. Then what is the job of phrenic nerve? Phrenic nerve is basically the one which supplies motor supply to the diaphragm, and as we take deep inspiration, diaphragm descend down. So if phrenic nerve is not working, then the diaphragm will not descend down on the same side, means that dome will stay higher. Normally, both of the domes should go up and down in breathing. But if right-sided phrenic nerve is not working, then the dome will stay high. So this kind of a breathing, that you can consider as paradoxical breathing. Or in this question, what you want to find is, where is the phrenic nerve? So what exactly are we looking at? We are looking at the neck region, and this question is obviously INI-CET exam question, AIMS question, and ABCD marker are given. Because I would like to go in a rapid way, so let me tell you here, this marker A, as I am shading it now, is going quite posterior to a muscle which I will shade now, the trapezius muscle. So this is the trapezius muscle, and the nerve A is none other than spinal accessory nerve. So if spinal nerve marker A is compromised, difficulty showing the shoulder, that will be the problem. Now, what is marker B? Marker B actually cannot be seen until you would have removed a large vessel from here, actually two vessels, carotid artery and intrajugular vein. So they already have been removed. And this marker B is sympathetic chain here, having this ganglia also in between. Now, what will happen if sympathetic chain is damaged? Sympathetic chain is damaged, like there will be a lot of problems, like one of that will be Horner syndrome. So marker B is the sympathetic chain. What about the marker C? Marker C, as you see, is coming from cervical plexus and is running in such a way that it is crossing the scalenus anterior muscle, lateral to medial. Phrenic nerve, that is your answer. So how do you identify phrenic nerve? It comes from cervical plexus, root value C3, 4, and it crosses the scalenus anterior, lateral to medial. I'll show you a diagram now. But what about marker D? Marker D is medial to phrenic nerve and is also running along with the sympathetic chain. So this marker D, first of all, you see it is coming from the head neck, means head region, not the neck region, and is running along with the sympathetic chain and is vagus nerve here. Now there are a lot of details here, but we don't want to go into those details. Since the question is asking for the phrenic nerve, a paradoxical breathing, diaphragm in question, so we'll keep our answer as C. Now let me show you a diagram here. As you see this diagram, it's the same story as I told you, and you're looking from the front view and you can see some details again. This time I would like you to focus upon some other areas as well. See, this is a vein under clavicle, subclavian vein, and if you are looking at this is subclavian artery. Why do you keep vein anterior and artery posterior? Because vein are thin walled, so it is better you keep them more superficial, artery will be deeper. And they are sandwiching the tendon of a muscle, which is scalenus anterior muscle. And this scalenus anterior muscle, which you see here, is basically coming from the cervical vertebra and inserting on first rib. So this tendon of scalenus anterior muscle will be sandwiched between the subclavian vein anterior and subclavian artery posterior. These two vessels are under clavicle, so subclavian is the name. Now, if that yellow color which I marked is the scalenus anterior, where is scalenus medius? It will be slightly posterior, and this is scalenus medius on the posterior side. And sandwiched between the two, it is interscalene triangle. In the interscalene triangle, you will see not only this artery which we have just marked, that is subclavian artery. Vein is not in the interscalene triangle, the artery is. So subclavian artery is content plus the brachial plexus. So you'll see this is the lower trunk of brachial plexus, which is in the interscalene triangle. There you give if you want to operate on the upper limb and you want to give the brachial plexus block, it can be given in the interscalene triangle, and you have to go between the two muscles, scalenus anterior and scalenus medius. Anyhow, this diagram which is along with it, I'll show there as well. If you are looking at the vein, you see this is the vein, the subclavian vein. And if you are talking about the artery, which we have put in green color, so this is the artery, subclavian artery. And what is between the two? What are they sandwiching? We have shown in yellow color. So that is the scalenus anterior muscle. If that is yellow color which I am showing is scalenus anterior, where is the medius? It is posterior and not very clearly seen, but the thing is, we wanted to talk about the brachial plexus, and here is the brachial plexus, especially the lower trunk. And there can be problems like scalenus anticus syndrome and all that. Then this lower trunk can be compromised. Lower trunk means C8T1. C8T1 means the hand muscles will be compromised, and there can be problems like tingling sensation in the territory dermatome. And if the brachial plexus is too much compromised here, claw hand deformity. lower trunk of brachial plexus, claw hand deformity, something like clump case palsy. All of these are questions and very much expected questions. So as such, if we go back, the question is asking about paradoxical breathing, diaphragm problem, unilateral, and the phrenic nerve. So choice number C, marker C, is identified. How? Because it's phrenic nerve. Now let me show the phrenic nerve in the diagram which we were actually talking about. Let me use some other color if possible. Maybe I'll use green here. So this is going to be the phrenic nerve. See, first of all, it will come from cervical plexus. It will cross the scalenus anterior muscle, lateral to medial. So that is how. Now you will say that, sir, this is too much of a complicated diagram. Don't blame me. Ask your examiner. Why do they give you such questions? But if they give the questions, you should be ready to find the best possible answer. And my job is try to make it simple, but most important is make sure that you get your answer. Okay, let me look in the chat. Can't see the picture clearly. Why? Why? Blurred. Okay, that is an issue. हाथ में क्या हो गया सर? नहीं, हाथ में कुछ नहीं हुआ. ये जो मैंने पहना हुआ है, ये this is actually I'm using iPad palm rejection, because I use pen. If my palm touches the iPad, then it will not detect my finger, it will detect my palm. So this blocks. This is a sleeve, it will block the touch. So nothing wrong. My hand is perfectly fine. No clump case, palsy or anything. I believe there is something wrong with the clarity of the picture, but how to prepare anatomy for the FMG exam? Yeah, of course. See, whatever we teach is for all the streams, FMGE or INI-CET, NEET PG, USMLE. Only thing is the level of asking question, the standard keeps on changing. So if I have taught you all this, FMGE, I think 10 or 12 questions are already taken care of. Okay, students. Yeah. So I believe there was some issue with the iPad connection which I was using. When we depend upon machines, it is always better to stand in front of the students and write on the board. That is the way I do. So maybe this thing will not work. I am using the other technique now. It is on my desktop, but the only issue will be I won't be able to write as such. So we'll just try to manage this way. So this was your question, and it was asking about the phrenic nerve, and phrenic nerve is here, marker C. Choice number C should be our answer. Echoing. What is echoing by? Anyhow, so we are moving further. What about this question? After cervical surgery, shoulder abduction is not possible due to lesion. Some root value they are asking. And writing would be better, I know, but the iPad is not getting connected with the Zoom thing, and you saw there was a lapse of, there was some lapse in the, right. So after cervical surgery, shoulder abduction is not possible, and due to lesion of what? You see, if we are talking about shoulder abduction, embryologically, the proximal muscles will have the proximal root value of brachial plexus, which will be, yes, as you are giving correct answers, it will be C5. C5, 6, but more precisely C5, subduction of the shoulder, and basically it is done by the deltoid muscle. Now, if you say C5, 6, C5 is more precise because C6 goes more in favor of anterior arm muscles like elbow flexion. Now, elbow flexion, it will be like biceps brachii, which is helping for elbow flexion, and C5-6 is the root value. If you want to do extension at the elbow, then you add one more, and that will be triceps, and it will be C7. So, to be very precise, shoulder abduction means deltoid like muscles, C5. And if you want to do elbow flexion, then C6. And if you want to do elbow extension, C7. Now, the point is, when there is Erb's palsy and upper trunk of brachial plexus is compromised and the C5-6 root value is compromised, what happens? Difficulty in shoulder abduction, number one. And number two, there is a problem with elbow flexion. Now, if the shoulder abduction is not possible, what will happen? Shoulder will remain in ADD, adduction deformity, policeman tip hand deformity. And if the elbow cannot flex, then obviously the other muscle, that is triceps, become more powerful, and it will keep the forearm in extended elbow. So adducted arm extended elbow is a problem in Erb's palsy, policeman tip hand deformity. Like one of the student was asking, is it for FMGE or not? See, this question is FMGE question. So I cater to almost all the extremes you may be having. My questions will be from INI-CET, it will be from USMLE, it will be from FMGE, because as a teacher, I should be taking care of all the students. So don't worry, and don't think that this question might not appear in INI-CET. It can definitely come in INI-CET. So, and NEET PG, of course. So, as such, shoulder abduction, so C5 should be our answer. Now, to add some more detail, you see, what will happen if there is clump case palsy? Lower trunk is compromised. If lower trunk is compromised, C8, T1 is compromised. C8 is the root value for hand muscles, basically forearm muscles also, but hand finger flexion basically, because you know finger flexion is done by forearm muscles. Flexor digitorum profundus, flexor digitorum superficialis, C8. So finger flexion will be a problem. And what about T1? If you're talking about the T1, then T1 is the hand muscles, and say for example interossei, lumbricals, and now what is this they are showing? Pad and dab. Pad, palmar for adduction, and dorsal for abduction. So palmar interossei are for adduction, means bringing the fingers towards the middle finger, palmar for adduction, and the dorsal is for abduction. But the thing is, because T1 is compromised, there will be a problem in adduction as well as abduction. In fact, that is not the major issue. If it is clump case palsy, root value C8 T1 involved, lower trunk involved, problem will be, let me just show this. Lumbrical and interossei together, there are 12 muscles and they do this normally. Means they cause MCP flexion, metacarpophalangeal flexion, and interphalangeal extension. This is normal. But if there is clump case palsy and the lumbrical interossei are not working, then MCP joint goes into hyperextension and interphalangeal joint goes into flexion deformity and what is called claw hand deformity. So claw hand deformity is due to injury of lower truncobrachial plexus. Root value involves C8T1, and the problem is with lumbrical and interossei, and maybe adduction is not so much paramount. What is more important is if the hand is in claw fashion, then it is very debilitating. Now, this is clump case, and if you compare it with the Erb's palsy, this is Erb's palsy, which is upper trunk injury, C5, C6. I told you, if you want to take the shoulder in abduction, you need C5. But if C5 is not working, then the shoulder will remain in adduction. Plus, lateral rotation also requires C5. And if the lateral rotation is not happening, the shoulder remains in medial rotation. This is policeman tip hand deformity, where the shoulder joint is in adduction and medial rotation. The elbow remains extended because triceps has become more powerful. C7 root value is for triceps. C5, 6 not working, C7 is more powerful. Plus the forearm goes into pronation because biceps is a powerful supinator. Now the thing is, it might appear that I am taking care of one question here, but if you have well read, there are some 20 MCQs already taken care of. They can simply ask you, what is the function of biceps? The function of biceps is, of course, elbow flexion, but it is a powerful supinator. Also, its root value is C5-6. It is compromised in Erb's palsy and leading to extended elbow and pronated forearm. So like that, you should be, because it's a rapid session, so that's why I'm going a bit faster. Otherwise, like how do I teach? I always like to go a bit slower. Anyway, after cervical surgery, shoulder abduction not possible, so our answer should remain C5. I'll ask you, in the previous question, when we were talking about this brachial plexus, lower trunk, between the scalene muscles, scalenus anterior and scalenus medius, what if there was a scalenus anticus syndrome and this brachial plexus was compressed between the two scalene muscles? Clump case palsy, root value C8 T1, and will there be a motor problem or sensory problem? Remember, always it begins with sensory problem, tingling sensation, sensory disturbances, but then it may result in motor manifestations and claw hand deformity, of course, if it is severe. Okay. All right. So we are continuing further, and we move further. As we go further, we will see, this is one question asking. See, these are very simple questions as such. And my point is that though we might be knowing the answer, but we have to add the details and we have to revise things quickly. The biggest problem with us is that we think that simple things are simple and we already have read them, we already know them, and in the exam hall we go and we make mistakes, we make blunders, and then we curse ourselves that how could I make such a blunder in. The problem is that we don't revise. Maybe it is the simplest of things, but you have to revise, and revise doesn't mean that okay, I have read one time, two times. See, there can be no maximum for revision, but at least 2 revisions should be there. So it appears, what kind of question is this? This is a very simple question, but you have to revise it, and revise it within a month of your exam. Means we have a great tendency to forget things. So muscles involved in overhead abduction. Overhead abduction means you have to take your hand above the head, which is basically more than 90 degrees of abduction. at the shoulder joint. So overhead abduction, they are asking for exception. And before I answer the question, let us go here. See, when we talk about the shoulder abduction, it is to be understood that one thing is the humerus will go away from the body. One component, but the other component is the scapula is also rotating and giving contribution. The ratio is 1:2. Say for example, if you are doing 180 of movement, that is overhead abduction, then in that 180 of movement of the shoulder abduction, 120 of movement is contributed by the humerus, and the 60 means the ratio is 2:1, as I told you, is by scapular rotation. A question came, scapula rotates how? When there is shoulder abduction, is it medial rotation or lateral rotation? And you should say it is lateral rotation. So lateral rotation of scapula happens so the glenoid cavity is directed upwards. Because the humerus is going upward, you have to direct the glenoid cavity upward. So once again I'll repeat, if you are talking about overhead abduction, 180 of abduction at shoulder joint, the humerus will contribute 120 of movement, and scapula will contribute half of that, 60, total 180, and scapula will rotate laterally. Plus it will be pulled anterior also by serratus anterior. Serratus anterior pulls the scapula forward, protraction of scapula. But along with serratus, for this lateral rotation, along with serratus anterior, you need trapezius. So trapezius muscle and the serratus together are for overhead abduction. Now, remember, though we say that 0 to 15 this muscle, 15 to 90 or 100 this muscle, be careful. In BD Chorostia, it might be written a lot of things, but like if you read Gray's Anatomy, all these muscles are active throughout. From 0 to 180, all the muscles are active. Only thing is, like, which one is more active is mentioned here. So when you say supraspinatus is working for initiation of abduction 0 to 15 and supplied by suprascapular nerve, it doesn't mean that after 15 the supraspinatus will be flaccid. It will remain in contraction, but its major activity is from 0 to 15 of shoulder abduction. Similarly, you said deltoid is from 15 to 90. Some books will say 100 supplied by axillary nerve. But the point is, deltoid is not relaxing in 0 to 15 It is working. And of course, working more when 15 to 100, and doesn't mean that after 100 it will stop working. It will work throughout 180. All these muscles are active in 180. Only thing is, the range is mentioned because in particular range, this particular muscle is prominently working. So I told you trapezius and serratus, both of them are working together, and they will be for overhead abduction. Overhead abduction, why do you need that? Like, I want to comb my hair. If you want to comb your hair, you have to do overhead abduction. And let me tell you one thing. I went to Kasoli and somehow I slipped, and I had this frozen shoulder. I could not take my arm up here, supraspinal tendinitis and all that. So, you know, teaching is one thing, looking at a patient is another. Being a patient yourself is another tragedy. So then of course, I am an anatomist. I was thinking like what went wrong and which muscle should I work upon and what kind of physiotherapy. And I never go to any physiotherapist because I do things as much as possible myself. So I improved myself, and plus Dr. Apoor helped me a lot. He caught me and injected one steroid into my capsule by anterior approach. So thanks to Dr. Apoor. Normally we meet, we hug with each other, and he could notice that one arm is strong, the other arm is not strong, and he immediately detaches me from himself and sir, what is wrong with your shoulder? And though I was not very keen, he injected some steroid here, and I am perfectly fine. 90% improvement. So anyway, and now the thing is, muscles improved, muscles involved in overhead abduction, or of course deltoid is working throughout 0 to 180, and 15 to 90 or 100 it is most actively working. Trapezius and serratus, both of them are definitely important. What is the nerve supply to trapezius? Spinal accessory nerve, serratus anterior, what is the nerve supply? Coming directly from the roots of brachial plexus, C5, 6, 7. Long thoracic nerve. So long thoracic nerve to serratus anterior. Pectoralis major is the nerve of exception. Now, why such difficult question is asked? Should I tell you frankly? Because of population. We are 100 students giving the exam. There are only 10 seats. And all of us are hardworking. How will I choose 10 out of 100? The major culprit is population. And the other culprit is politician. So P and P, population and politician. Population culprit because 100 students and 10 seats. So if we were only 10 and 10, then fine. And politician, why? Because politicians, they should make sure that if 100 MBBS seats are there, 100 PG seats should be there. They should make more of aims as they are doing. Modi government is doing great things, which I am quite happy about. And doesn't matter, like Modi himself is not doing, it is you people who are doing. And we should just support a leader who is thinking positive. So if we had 100 seats, 100 PG seats, then they will not give you such difficult questions. Like this is, no, right now, this is not a very difficult question as such, but tough questions are given because they have to choose. And it's a difficult job for the examiner also. Maybe even the examiner is not happy by putting you in such trouble, stress. So anyhow, life goes on. So why pectoralis major is not helping us in the overhead abduction? So let us see. You will see here. See, pectoralis major is a large muscle. First of all, it is a convergent muscle because large origin and the insertion is very small. But be careful, be careful. Though it is a convergent muscle, that is not your answer when a question came that pectoralis major is a convergent muscle or a spiral muscle. So it is both. It is convergent muscle because such a large origin and such a small insertion, it is a convergent muscle, no doubt. But then it is a spiral muscle also, and there are very few spiral muscles. Spiral because the upper fibers, they are inserting down, and the lower fibers, they are inserting upwards, and in that process they spiral. So if somebody asks you, pectoralis major is which kind of muscles, spiral or convergent? You say both, but then the examiner is persistent. No, tell one answer. Most preferable answer, then you should say it is spiral, and then you can say it is convergent. Okay, so pectoralis major, why is it not helping us in ABD, abduction? Why? Because it's a simple rule. You know, the rule is any muscle fiber which will cross the shoulder joint anteriorly will be pulling the humerus close to the body. You see, you have to look at the inserted fibers. It will not work in such a way that the humerus will go away from body. It will pull the humerus close to the body. That is ADD adduction, not abduction. So it is a muscle which is for ADD adduction, not abduction. It cannot help in abduction. Plus, it will also pull the humerus close to the body. So flexion. See, it is ADD adduction, flexion also. These are the functions of pectoralis major. So I hope it makes things clear. And as you see, muscle involved in overhead abduction are all except. So we should answer it as pectoralis major. What is the nerve supply to pectoralis major? From the brachial plexus, medial pectoral nerve, lateral pectoral nerve. Now when you say medial pectoral nerve, lateral pectoral nerve, it's a big muscle. So two nerve supply, hybrid muscle, a muscle having more than one nerve supply, medial pectoral nerve, lateral pectoral nerve. And also remember, lateral pectoral nerve will come from the lateral cord of brachial plexus, and the medial pectoral nerve come from the medial cord of brachial plexus. So medial cord and lateral cord, both of them are supplying the muscle. So all of these are MCQs. You see, in my teaching, somehow it happens that I speak, whatever I speak, they're all MCQs. Either they have been asked or they are about to be asked. So it's good for you. You know, हिंदी में कहते हैं कि जैसे सत्संग सुन रहे हैं, अमृत वचन जो भी बोलेंगे बहुत अच्छा बोलेंगे. I think we are blessed people, or maybe we work hard, you know, we work hard so that we don't speak nonsense or useless things. Automatically, things which come to our mind and we speak, they are all important. And by God's grace, like we have been in the system for quite long, 20-21 years, the system we follow is foolproof. It works. It all the time works. But see, I cannot go with you in the exam hall. It is you who will be going there. And my job is to keep you on track, guide you, and train you to work hard and strategically. These are strategic exams, and you should minimize your mistakes. That is very important. We are prone to make mistakes, and we have to minimize them. Okay? All right. Let me just go through the chat. Yeah, FMGE exams are easier, no doubt, no doubt. If you're telling spiral muscle is trapezius, I doubt about that. Spiral muscle, if you want, then it will be another one, lower back muscle. That is the, what is that? Latissimus dorsi. Latissimus dorsi muscle has spiral fibers. So two examples I'll give you for spiral. Lower back muscle, latissimus dorsi, has spiral fibers because it is inserting here, and even this pectoralis major is inserting here. Both of them have spiral fibers. Trapezius, I really doubt you can consider as spiral muscle. And okay, fine. So yeah, fantastic. You people are already giving answers perfectly. Right, so let us move further. And as we move further, you see, this is one question which persistently coming. Like, we would like to teach those topics which are continuously repeated topics, and questions may not get repeated, you know, but topics are always repeated. So you have to strengthen the topic and take one thing from me. Take one thing from me. I have seen in AIMS exam, it used to happen. 80 questions, 80 questions are ditto from some 2-3 years back exam. Now I'm wondering why, how could they give the ditto questions in the exam after 3 years? And I was just trying to, because I have a very scientific, logical mind, I always try to find out. We have been trained like that, like reasoning should be there, logical, and people like AIMS people, they're not somebody walking on down the road, like they are very intelligent people. Why would they give repeat questions? And then I realized that students, that is because the students are not answering them correctly. Students keep giving wrong answers. Then what is the need of giving a new question when already the questions which you give students answer wrong? So they will continue. You know, preparing a new question takes time, efforts. There's no need. Already students are answering it wrong. So let us continue. So it's a dangerous question which keep on repeating itself because nobody has got the perfect answer yet. And the moment students start answering it perfect, the question disappears and then some new question will come. So be careful about a question which keep repeating itself, because you are you are under the confidence, you have a wrong confidence that I know the answer, but that is not the answer. And that is where we, that is our expertise. We really struggle to find the correct answer and deliver it to the students so that the system keeps working. Anyhow, mention action of the muscle on the hip joint as marked in here. This is humerus, and head of the humerus, neck of the humerus, the greater trochanter, lesser trochanter, and the shaft of the humerus seen from the posterior view. This is gluteal tuberosity, where 25% fibers of gluteus maximus will be inserted. Now, if you say 25% fibers of gluteus maximus inserted here, then where is the rest of 75%? rest of the 75% fibers of gluteus maximus are inserted on tibia by iliotibial tract that I will show. So this is gluteal tuberosity. The name is suggesting it will have the insertion of gluteus maximus muscle and 25% fibers, and then 75% fibers, they will be merging in iliotibial tract, and then they will be inserted on tibia. They have some function on tibia. Okay, so what about these 25% fibers which are inserted here? Again, you know, see, examiners are very knowledgeable people, of course, and the more you dig, the things become more complicated. Take it from me. So even here, when the fibers are inserted, upper fibers will have some other function, lower fibers will have some other function, because it is all kinematics, kinodynamics. So upper fibers will be doing something else, lower fibers will be doing something else, because it is the axis on which the joint is working. But anyway, see, you should remember the basics. Simple thing is, if gluteus maximus is in question and if it is crossing the hip joint posterior, then it will pull the femur posterior. Simple. If gluteus maximus is a posterior muscle and it is inserted posterior to the humerus, sorry, this femur, then it will pull the femur posterior. And if you pull the femur posterior, extension is, it is the chief extensor at the hip joint. That is point one, which everybody should know. Number two, what will it do? Will it be doing lateral rotation or will it be doing abduction? And that is where, if you read Gray's Anatomy, things become more complicated. Now, before I comment upon the answer, you just see here. This is posterior view of the right hip joint. As you look at the posterior view of the right hip joint, the origin of the muscle is from the ilium bone, sacrum bone. There is some ligament also, sacrotuberous ligament and all that. And the muscle is inserted 25% on gluteal tuberosity, which is the upper end of the femur bone, gluteal tuberosity. And the rest of fiber I'll show in next diagram. The thing is, if the muscle is crossing hip joint posterior, it will pull the femur posterior and it will be chief extensor at the hip joint. That's the very first thing. Second thing, looking from slightly side view, the gluteus maximus from posterior side and tensor fascia lata from anterior side, both of them coming from the hip bone, they are joining together to form iliotibial tract, which is a modification of the deep fascia on the lateral aspect of the thigh. If you feel your thigh laterally, you'll find there is a band, a tough band, collagen fibers like tendons, tendinous insertion. So gluteus maximus, a big muscle from posterior, and tensor fascia lata, small muscle from anterior, and inserting on this iliotibial tract, which is basically, thickening of the fascia lata, the deep fascia of the thigh laterally, and inserting on Gerdy's tubercle, Gerdy, G-E-R-D-Y, Gerdy's tubercle, on the anterior aspect of the tibia bone laterally. Watch my words. It is inserted, the iliotibial tract is inserted on the Gerdy's tubercle, which is on the anterior aspect of the lateral condyle of the tibia, anteriorly, lateral to tibial tuberosity. Because on tibial tuberosity, you have the quadriceps tendon inserted, so lateral to that. Now, what is the function of these two muscles when they are working on the tibia? First of all, many of you won't be knowing that gluteus maximus inserts on tibia. So they don't have much function as such, means about movement, but they stabilize the knee joint, especially when standing straight or when you are bending and standing up. Then they are stabilizers basically at the knee joint. That is there. But the function, as you ask for gluteus maximus, let us proceed further. You see, this is how you check the gluteus maximus muscle. You ask the patient to lie down prone, and then you stabilize the hip joint with one hand and ask the patient to extend the lower limb, that is thigh. And not only extend, you have to kind of put a resistance that you don't allow that. So you will see the power of the gluteus. One hand which is put here, it can see the contraction in the muscle. Sometimes gluteus maximus may be weak, so you can make out. So feel for the contraction and feel for the power, give resistance so that the patient is unable to do extension. And plus this leg should turn lateral. Lateral rotation of the femur. That is also one of the function of gluteus maximus. So one function is extension, other is lateral rotation. And how lateral rotation, if you wish, you can just imagine here when the muscles will be contracting, you will be rotating the femur. And if you pull femur inward, then of course it will do lateral rotation. So it is not only an extensor muscle, it is a lateral rotator also. And other thing is, if you remove the gluteus maximus, deep to that there are so many short muscles, they are all lateral rotators under cover of gluteus maximus. So those short muscles which are under cover of gluteus maximus and the gluteus maximus itself, they are lateral rotators. But be careful now. These muscles, like if you want to name, we have removed the gluteus maximus, and then you can see piriformis muscle, or maybe the superior inferior gemellus, then the obturator internus, the quadratus femoris. So quadratus femoris is down here, quadrangular muscle attaching to femur, superior inferior gemellus, piriformis. But be careful, don't talk about the gluteus medius and gluteus minimus. No, gluteus minimus, gluteus medius are abductors and medial rotators. They are abductors and medial rotators. So they are different. And if you talk about the gluteus maximus, which we have cut here, then it is extensor and it is basically lateral rotator. Okay. Though I'm holding some information here because unnecessarily, why should I confuse you people unnecessarily until otherwise the examiner is asking questions. Okay. Now, fine. I believe all of you are comfortable with gluteus minor extension and lateral rotation. See, if you're asking for the gluteus medius and gluteus minimus, then they are abductors and medial rotators supplied by superior gluteal nerve. You see, this is superior gluteal nerve supplying gluteus medius and minimus. If you are talking about the gluteus maximus, then it is supplied by inferior gluteal nerve, and I told you extension and lateral rotation. So let us go back to the question, and you can see that now if you have to choose, then I will go for choice number B, extension and lateral rotation. Okay. So we proceed further now, and as we do so, type of joint present at middle radial ulnar joint. Now, I remember long back, there's a question, AIMS people, I understand like AIMS professors are quite knowledgeable people, quite high degree of wisdom, and but the issue is like there is a mismatch between us, isn't it? They are so wise and we are just newcomers. They asked a question in supination and pronation. Is the middle radial ulnar joint working or not? Question was different, but they were asking supination and pronation, is the middle radial ulnar joint working or not? Or let me give you the question. Question was supination pronation occurs at superior radial ulnar joint, inferior radial ulnar joint, middle radial ulnar joint, wrist joint. Choose the exception. So question was supination pronation occurs at all except, choices are superior radial ulnar, middle radial ulnar, inferior radial ulnar, and the wrist joint. I'll tell you, there is no answer here because all of them are working. Now, even if all of them are working, then you have to choose that which is least probable. Then people thought that how could wrist joint help in supination pronation, because basically supination pronation is a movement of radius rotates. Then what is the role of wrist there? But you read, not even later I found in grades it was given, but there are some intercarpal joints which are working for supination pronation. So the point is, middle radial ulnar joint is slightly mobile joint and contributes slightly to supination, pronation, not majorly. So that was the answer of exception. So middle radial ulnar joint definitely will help in supination, pronation, but very minor because it's a fibrous joint, you know, and movements occur at synovial joints. Movements occur at synovial joint, not the fibrous joint. Fibrous joint can assist, but they are not the major joint of movement. So you mean to say middle radial ulnar joint is a fibrous joint? Yes, it is a fibrous joint, interosseous membrane between radius and ulna, fibrous. Okay, fibrous, fine. But then, what is this primary cartilaginous? What is this secondary cartilaginous? So, as you would say, that sir, again this joint topic, again you all the time you keep teaching joint, and it may be tragic, but let me tell you, despite you being very confident about joints, classification, examples and all, you are going to make blunders. So a humble request, sincere advice, don't take things lightly. Okay, revise and revise. So let us do that. This is joints. Joints can be classified by various methods, but one method is their mobility. So restricted mobility and freely mobile joints. So which joints are having restricted mobility? Like fibrous joints have restricted mobility and cartilaginous joints have restricted mobility. Otherwise, synovial joints are freely mobile joints. Now, synovial joints are freely mobile, fine. What about the restricted mobility? They are called solid joints also, solid joints. Fibrous joint and cartilaginous joints are solid joints. And then they have subcategories. Like fibrous joint themselves will be of three types: restricted mobility and three types. Skull. Skull will have sutures. Like one suture is in the nasal septum, you know, from below comes the nasal septum bone, the vomer, and from above it is the sphenoid bone. So sphenovomerine joint, which I am showing here. The sphenovomerine joint is a shindylasis. Shindylasis. It was a question 2 times. Shindylasis spelling will be S-C-H-I-N-D. Shindylasis. D-Y-L-A-S-I-S. So shindylasis. So shindylasis is a suture type of joint, and it is in the skull, of course. Nasal septum, midline joint, sphenovomerine joint. Immobile. So sutures are immobile, and this is tooth and socket joint. Tooth and socket joint is again immobile, and both of them are in skull. Now, third example of fibrous joint is here, syndesmosis. It is called syndesmosis, like we said, middle radioulnar joint. So middle radioulnar joint is syndesmosis, and it is slightly mobile joint. So you see the difference is fibrous 3 types: the suture, the gum fosses, and the syndesmosis. But the suture and gum fosses are immobile. Syndesmosis is slightly mobile. Now one more example they'll ask you for syndesmosis, slightly mobile joint, fibrous joint, is inferior tibiofibular joint. Inferior tibiofibular joint is a syndesmosis, slightly mobile joint. Okay. Now cartilaginous. In cartilaginous, there is primary and secondary. Primary is here, secondary is here. Primary has one more name, synchondrosis. Synchondrosis. So synchondrosis is primary cartilaginous joint and immobile. For example, epiphyseal-diaphyseal joint in the growing children. So epiphysio means the end of the bone, diaphysis means shaft of the bone. So epiphysis, diaphysis joint in the growing children. The 2 bones united by a piece of hyaline cartilage. When the 2 bones united by a piece of hyaline cartilage or synchondrosis, primary cartilaginous joint, immobile joint, versus the symphysis, secondary cartilaginous joint, symphysis, usually in the midline. So what is the structure of this slightly mobile joint? One bone attaches to other bone, making a joint, itself lined by hyaline cartilage, and then sandwiching between is a fibrocartilage. So if you look at the pubis symphysis, you'll find that there is a hip bone on one side, hip bone on the other side, and both of them lined by hyaline cartilage. And sandwich between the two is fibrocartilage. So pubis symphysis, one example. The other example is midline intervertebral joint. One vertebra connected with other vertebra in the midline. So each vertebra is lined by hyaline cartilage, and then intervertebral disc is lying between the two, which is like a shock absorber fibrocartilage. It is a fibrocartilage. It is a shock absorber between the bones. So again, what is the joint type? Secondary cartilaginous joints, symphysis, mostly they are midline joints and they are slightly mobile joint. And here each vertebra is already lined by hyaline cartilage, and then sandwiching in between is the fibrocartilage. That is the structure. Okay, now what about the synovial joints? Synovial joints, now there will be many examples and the examiner will be interested in asking so many details, but one which they have asked recently is when the rib is articulating with the vertebra, costovertebral joint. The costovertebral joint, which can be again subclassified like the rib articulating with the body of vertebra and then articulating with the transverse process of the vertebra. So one could be costo-transverse joint, one is costovertebral joint. So costovertebral, where the costo is the rib. So costovertebral means it is with the body of vertebra. Costo-transverse means the rib with the transverse process of vertebra. Both of them are plain synovial joint. Now, if they are plain synovial joint, why do we need synovial joint here? Freely mobile joint here? Because you are breathing. When you are breathing, your ribs are moving, and when the ribs are moving, they should move freely. So that is why they need this plain synovial joints. Okay. All right. So let us go back here, and there was nothing much here as such. Type of joint present in the middle radial nerve joint is of course a fibrous joint. It is a syndesmosis. One other example of syndesmosis is inferior tibiofibular joint. Primary cartilaginous, if you want the example, we have seen the epiphyseal-diaphyseal joint, immobile joint. Secondary cartilaginous, we have seen some example, pubis symphysis, midline intervertebral joint, and plain synovial we have seen the costovertebral, costotransverse joint. Okay. But my advice is that whatever notes you have made, you must revise them, because there are several other questions. And a very simple, genuine advice that keep practicing as many MCQs as possible. At least, in a day, you should do 20 MCQs per day and with explanations. Means if you are doing MCQ, then it is always good to know the answer, and it is always good to know why others are not the answers and when they will become the answer. So this is the approach to deal with the MCQ. And if you are just doing a MCQ and just looking for answer, then 200 MCQs per day. So 200 MCQs per day if you are just doing the question and answer, but that is not the good way. Good way is that you look at the question and search for the answers and try to practice new questions, not the same question which you already have practiced, again practicing that. After some time, our brain becomes, like in drugs, in pharmacology, what do you say, drug tolerance, or what you can say. You will read, you are spending your time, energy, but the brain will not register it. Until you challenge your brain, the brain doesn't work. So you are thinking that, yeah, okay, I have read this, I am reading again, and this is fifth reading. It is useless because it is passive. And anything which is passive, and you are wasting your time. So always try to challenge yourself. And it's better that you read with explanation. Okay, that is my advice, and it is upon you. You are all wise people. A teacher can just give you some insight, and it is not necessarily that whatever I say has to be followed like some पत्थर पर लकीर खींच दी, ऐसा कुछ नहीं होता. आपकी अपनी मर्जी है, आप अपने अपने हिसाब से करेंगे. भगवान ने हर किसी इंसान को अपना मतलब सब लोगों को अच्छा दिमाग दिया हुआ है. वो अलग बात है कि आप उसको कहाँ इस्तेमाल कर रहे हो. तो tachyphylaxis, what is this tachyphylaxis? Gomphosis, I don't know, man. What is this tachyphylaxis? Sometimes we learn from you students. I'll have to check what is this tachyphylaxis. Okay, anyway. So we move further, and yeah, arrow marked surface projection are absent in. So means you have to It's an answer where you have to do the exception thing. And these thread-like structures, they are all thread. Cilia. And if these are cilia, then what is this pinkish line, this dark pinkish line? What is this? Sometimes it can give us a wrong impression of a microvilli. Like I was choosing some place, and okay, right, got it. Because I have read my pharma quite long back. I remembered. Yes, you are correct. Tachyphylaxis could be tolerance to drugs. Yes, Gaurav, fantastic. So like that, we might be having tachyphylaxis, means something which I have read and I'm reading it again and again. My brain will not register it, I'm wasting my time. So always try to look at one particular thing from various angles and do mock test, grand test, and practice some MCQs from here, there, from books, and watch some YouTube sessions. So look at the problem from 360 degree. And always keep challenging your brain. If you don't challenge your brain, it's learning become very slow, very passive, and you forget very easily. So keep challenging yourself. So here what I'm telling you is these thread-like processes, they are all cilia, and some student might be confused that this pinkish color is microvilli, basically striated border. But the thing is, no, it is not. Actually, these cilia, they move because they have this centriole mechanism. They have basal bodies, and those basal bodies take this stain, this pinkish stain. So this pinkish stain is for the basal bodies, the centriole mechanism, which is going to move the cilia. And we move the cilia to, say for example, respiratory tract, we have the cilia to move the mucus outside, cuff the mucus outside. So that is why the cilia have to be mobile. Now here, as you see, this is pseudo-stratified ciliated columnar epithelium. Pseudo-stratified ciliated columnar epithelium. And it is asking that this surface projection. Surface projection could be, microvilli, or it could be cilia, it could be stereocilia, like that. So where is cilia absent? Now, before I answer the question here, yeah, perfect, Gaurav, you have given perfect answer. So you see, stereocilia, as we see, this is male reproductive system now, and we have taken a section histology slide and we have magnified it. Maybe it is epididymis or maybe it is ductus deferens. So it could be epididymis, it could be ductus deferens. Pseudo-stratified epithelium is there. Columnar, pseudo-stratified columnar epithelium is there with stereocilia. Now, if it is stereocilia, it appears like cilia, but it is not cilia. It is a long microvilli. Long microvilli. Now, you would think that why would we need microvilli in the vas deferens or ductus deferens? For absorption, of course. What is the purpose of microvilli? For absorption. But then why the microvilli are so long and appearing like cilia? And that is why the name is given stereocilia. They don't help us in any movement, basically. So in the ductus deferens epididymis, we have stereocilia. And it is a misnomer, basically, because it is not a cilia at all. It's long microvilli for absorption. So just for the sake of information, I don't want to go into much detail here. But that should be our answer. Okay, even if you got your answer, what about the female, the uterine tube? Female, the uterine tube, you definitely have ciliated columnar epithelium. And not only these thread-like processes, you can see these thread-like processes, they are all cilia. And why do you need cilia in uterine tube, in fallopian tube? We need cilia because when there is fertilization in the ampulla of fallopian tube, and from there the conceptus has to be traveling towards the uterus because it has to implant in the uterus. So the cilia in the uterine tube will be moving the conceptus towards the uterus. Though it is obvious that the uterine tube itself has this muscular wall, peristalsis is there, and that peristalsis will push the baby or conceptus towards the uterus, of course. So there are two things which are moving the conceptus from the ampulla of fallopian tube towards the uterus for implantation. Number one, peristalsis of uterine tube, Smooth muscles are there around the uterine tube, and the cilia also. And why I'm telling you that, why cilia is important, because sometime, though some authors may not mention at all, Carter-Jenner syndrome, which is immotile cilia syndrome, may result in ectopic pregnancy. So Carter-Jenner syndrome or immotile cilia syndrome may result in ectopic pregnancy. Why? Because maybe peristalsis is one component, but ciliary movement is another component. And if cilia is not moving, maybe the conceptus never reach the uterus. And if conceptus doesn't reach the uterus, it will implant in the uterine tube. Ectopic pregnancy, reduced fertility. So is reduced fertility a feature of Carter-Jenner syndrome? Yes, it is. But be careful, because I was teaching in Mumbai and then in Delhi itself, and I told the student specifically, actually the student told me, then I thought that okay, I should, because these are the topics which are in anatomy, pathology, medicine, your Harrison Medicine 21st edition, read it. Carter-Jenner syndrome is having certain features, but Carter-Jenner triad is a different thing. Though it is the same story, but in triad, Carter-Jenner triad, what you have to include is chronic sinusitis, bronchiectasis, and situs inversus, not infertility. So be careful again. I repeat my words. Immotile cilia syndrome, Carter-Jenner syndrome, can result in ectopic pregnancy, reduced fertility, is a feature of Carter-Jenner syndrome, should not be included in Carter-Jenner triad. In Carter-Jenner triad means only three things can be included, and they are chronic sinusitis, bronchiectasis in the lung space, pus collection, and situs inversus. And why situs inversus? Because the embryonal cells, they move with the help of cilia. If cilia is not working, then the organs are not placed accordingly as they should be, and the heart may be on the right side, the spleen may be on the right side. So situs inversus is a feature of Carter-Jenner syndrome. Infertility is a feature of Carter-Jenner syndrome, but is not included in the triad. So kindly go through that, and maybe it will be helpful. And now, situs inversus, chronic sinusitis, and bronchitis. Very good, Rohit. Very good. And Rahul, you have answered perfectly fine. Best reference. Gaurav, you are telling subfertility. That's great. Yes, great. So now, see, in our, I'm going according to the choices we have got. So ependyma. Now, if you say ependyma, what is ependyma? Ependyma is the epithelial lining of the ventricles of the central nervous system. So once again, ependyma is the epithelial lining of the ventricles of the central nervous system. What is central nervous system? The brain and the spinal cord, and they're hollow from inside, filled with CSF. The brain and spinal cord are hollow from inside, filled with CSF. That is, the ventricles are filled with CSF, and you move the CSF. And to move the CSF, there are many factors which will move the CSF, but one is cilia. So are you trying to say that ependyma also has cilia? Yes, but be careful. Ependyma not only has cilia, they have microvilli also. Some cells will have cilia and some will have microvilli, which is again a strange finding. Let me show you. So here is the CNS, the brain and the spinal cord. Central nervous system is brain and a spinal cord, and they are hollow from inside. Inside the hollow is the ventricles. Ventricles are filled with CSF. Like we have taken a transverse section of spinal cord now. So as you've taken the transverse section of spinal cord here, you will find that this is a central canal filled with CSF, and it will be lined by ependyma. So can't see nothing, so we magnify. This is the transverse section of spinal cord. As you can see, this is H-shaped gray matter. H-shaped gray matter means the neuron bodies. Now, if this is H-shaped gray matter, neuron bodies, what is in the periphery? In the periphery, there axons, the white matter. So periphery is white matter, and this is the gray matter here. But we are focusing upon central canal here, filled with CSF, and we have magnified the ventricle. V for ventricle, E for ependyma. This is ependyma. Now, This ependyma can't see nothing, so again magnified here. So this is the cavity or central canal. This is the ependyma. But I really doubt that you people would be able to see too much of details here. But the thing is, ependymal lining, it is maybe cuboidal or columnar. First of all, ependyma can be cuboidal or columnar. If you have to really, I prefer columnar. Okay, so columnar, ciliated columnar. Okay, ciliated columnar with microvilli. So be careful. It's a famous saying: the more I read, the less I know. The more I read, the less I know. And that is why we as teachers, we withhold a lot of information. We don't tell you each and everything because maybe you are just young people. You will be totally burdened. And anyway, I just take care of anatomy. You have to take care of 19 subjects. I cannot overburden you, but I will give you information only if I feel that it is now important and examiner is going to use it. So I'll repeat my words. Ventricles are lined by ependyma, and a lot of research goes into this to find out. And no research, just read Gray's Anatomy, it's already there. It is cuboidal cells and columnar cells, preferably answered as columnar, ciliated columnar, and with microvilli. Now you will say, okay, cilia, agree, they will move the CSF. Though moving CSF, there are other physical factors working. Why microvilli? Microvilli are for absorption. You mean to say, are you doing some absorption in the CSF? Yes, we are doing that. So that you remember. And what is the other option we have got? That was the respiratory tube, bronchus-like things. So this is one other example where you'll have cilia. So you see this diagram here. Pseudo-stratified ciliated columnar epithelium with goblet cell. You see, this empty-looking cells are goblet cells. One goblet, other goblet cell, some mucus is coming. That mucus will be moved by the cilia. And you know this dark pink color. What is this dark pink eosinophilic color? That is the basal body, centriole mechanism. And these are the nuclei of the columnar cells. So pseudo-stratified ciliated columnar epithelium with the goblet cell, that is present where? Respiratory tube. Yeah, but where? That is the trachea, bronchus and bronchioles. Now, when you say trachea, bronchus and bronchioles, what is this? Is this a trachea or bronchus? Is this trachea or bronchus? So you say this is not trachea. Now, why this is not trachea? Because it is appearing like trachea. If it is trachea, then you look at the cartilage. This is one island of cartilage here, one island of cartilage here, one island of cartilage here. Trachea has a single C-shaped cartilage. It is not broken like that, though it may appear in some sections, but there will be a C-shaped ring of cartilage, okay, not scattered like this, that at some places there, other places it is missing. So if it is one here, then nothing, no cartilage here, and suddenly one cartilage appear here, this cannot be trachea. It's very rare that trachea section might appear like this. Possibilities are definitely there, but this is not trachea. This is bronchus. Okay, now you say this is bronchus, fine. And why it is not C-shaped ring here then? If trachea is C-shaped ring, you should have C-shaped ring in the bronchus also. No, it is not there because the cartilage is being replaced by more of smooth muscles. More of smooth muscles will be there. So more of smooth muscles, but why smooth muscles are required? For bronchoconstriction, bronchodilation. Now when you say the cartilage is being replaced by the smooth muscles and the smooth muscles help us in bronchoconstriction, bronchodilation, which system works for bronchoconstriction? Sympathetic or parasympathetic? And it is parasympathetic. So, okay, I activate vagus nerve now. And vagus nerve, or say, there is a patient with asthma. And asthma is hyper-responsive tracheobronchial tree. So hyperresponsive means what? Means parasympathetic system become more powerful, more of acetylcholine will be coming, and it will be working. Tell me what will happen. Bronchospasm. There will be bronchospasm. Smooth muscle will narrow down the lumen. Plus, these glands, G glands, they will pour secretion into here. Now imagine, if a patient of asthma comes to you, how do they come? They'll be bronchi. Bronchi are there, and you will find that not only there is a bronchospasm, lumen is compromised, there is a lot of secretion inside the lumen. Acetylcholine is too much. So what do you do for such patient? One thing could be you just give them a spray, ipratropium bromide, just spray. So what is ipratropium bromide? It is anticholinergic. It is anticholinergic. It will counter the vagus nerve, because vagus nerve has become more powerful and it is causing that more of acetylcholine release, and that more of acetylcholine, parasympathetic activity has increased. The smooth muscles are going into hypercontraction, reducing the lumen, plus the glandular secretion. Smooth muscles of the glands, they have more of acetylcholine, they secrete more and they block the pathway. Patient can not breathe, may die because of asphyxia and suffocation. So you give ipratropium bromide, anticholinergic, you at least block the excess level of acetylcholine. Okay, so do we have cilia here? That was the question. Yeah, of course we have cilia here. Cilia moves the mucus, and we have to cough out the mucus. Whatever we inhale, there will be a lot of dust particle, bacteria coming in. You don't want the bacteria to reach the lung, so you have to expel it. So as we come back, arrow march surface projection absenting. It is cilia, and you already have answered that it should be vas deferens or could be the epidermis, because they are lined by the pseudo-stratified columnar epithelium with stereocilia. And what is ependyma lined by? Ependyma is ciliated columnar epithelium with microvilli. And oviduct, what is oviduct? It is a uterine tube and lined by ciliated columnar epithelium, yes. And bronchus? Bronchus, yes, bronchus is lined by ciliated columnar epithelium, no issue there. Okay, we move further, and this is one question which is persistently being asked, but maybe now the question will not appear because most of the students are answering correctly. So it's a simple, one student is asking, can we use atropine as it is also anticholinergic? Yes. Yeah, sympathetic agonist also. Yes, of course, you are very correct. See, if there is asthma patient, you can have two inhalers. Number one, ipratropium bromide you are giving, which is anticholinergic, and number two, salbutamol, terbutaline, you spray, that will be bronchodilator, sympathetic agonist. Yes, you are correct. Gaurav, you are perfectly fine. And N. Kumar, I'll answer your question. Lot of side effects of atropine. Gaurav, yes, Gaurav, I know. I'll give you one one of my experience. But at the moment, see, when we talk about asthma, we can have two inhalers, and one is ipratropium bromide, which will take care of the acetylcholine, anticholinergic. Other is salbutamol, which is beta-2 agonist, and it will cause bronchodilation. Basically, we want bronchodilation also, so that the patient feel comfortable in breathing. Now, atropine as such, rarely used drug intravenous. And say somebody has taken OP poison, organophosphorus poisoning. Now somebody has taken OP poison, not very happy with life, and I will die and so, and somebody picked him up and brought to the hospital, and you put a pipe into his stomach and open the tap water, and never ever in his life he will repeat this mistake again, because it's a tragic experience basically. It is much worse than dying actually. The lavage, gastric lavage. So these people who have taken this OP poison, again, it works the same way. Patient will drown himself in his own secretion. Organophosphorus poisoning is patient will drown himself in his own secretion. Lot of acetylcholine, and basically it is for the cockroach and for the flies. the acetylcholine will be there, they die, but now the human himself made himself cockroach and now he is dying. So they die because of pulmonary edema. There will be a lot of accumulation, collection, and they die because of respiratory failure, because of pulmonary edema. That is the cause of death in OP poison most of the time. Now the thing is, there you can use atropine. Atropine may or may not work actually, again, because OP poisons are also different types. Some may respond to atropine, and your patient has come. I am telling you, according to my experience, daily in our emergencies, these patients will definitely come, and it was a havoc. So we'll just put some tap water, some 2 liters of tap water in his stomach and make him vomit, and then make him lie down and push atropine. Break the vial, push, break the vial, break the vial, break vial. Full night you just keep breaking with the vials and pushing atropine. You saved your patient, because it'll dry the patient like anything, total dryness. And the other thing, it causes hallucination also. A lot of side effects. Atropine has a lot of side effects. Tachycardia will be there, and they mad as hatter, as written in your Kiriti body. They will be running around in the emergency ward from this end to this end, this end to that end. It's difficult to hold them. Then we tie them on the bed. You have to tie them, because otherwise they don't even sit on the bed. And some of them will be hiding under the bed. Now you're wondering why he's hiding under the bed. Photophobia. There's photophobia. You have put atropine, so much atropine in the body, photophobia. So they are hiding under the bed because it is dark. So all those experiences, you feel like laughing, smiling, but patient is in distress. You're not supposed to do all. You should have empathy there. But these are so funny people. First of all, you take some nonsense thing, and then you do all those things. But it is not under their control. So of course, atropine has a lot of side effect. Dryness, total dryness. Eyes are dry, nose is dry, mouth is dry, throat is dry, everything. Your gastric acid is reduced, everything. Sweat, no sweat. It's hot skin, red skin, and hallucinations. So all these are side effects of atropine. We usually avoid using atropine. Okay. So oximes, yes, pralidoxime, yes, correct. Rohit, very correct. Pralidoximes are used, and yeah, muscarinic blocker. They are, atropine is non-selective muscarinic blocker. Yes, fantastic. So, but we are talking about anatomy or pharma. Let me just go back to my axis. Reticular fibers. Reticular fibers are type 3 collagen fibers. Type 3 collagen fibers. And they are asking where they are absent. First of all, reticular fibers or type 3 collagen fibers, they are making basically a framework, kind of a network, like fishnet. Like fishnet, they make a network, and on that, lot of lymphocytes can be holding. So lymphoid organs. Lymphoid organs can have this network of reticular fibers. So a lot of lymphocytes can just sit there, just making a home for them. Now, if that is so, and you're telling that should be there in lymphoid organs, bone marrow can be considered as a lymphoid organ. In fact, in fetal life it was. Even in human life, you can consider it as a lymphoid organ. Spleen is, of course, lymphoid organ. They're all lymphoid organ here, but thymus is one particular special mention that it doesn't have reticular fibers. Now, if thymus do not have reticular fibers, then how do you keep those lymphocytes? Means you need some scaffolding or something where they can sit. The thymus has thymus reticular cells themselves, and they create the network. So in thymus, we do not have reticular fibers, and we have thymic reticular cells making a reticulum themselves. And it will become more clear when I show you diagrams. You see, this is reticular connective tissue. Okay. And location could be liver, kidney, spleen, lymph node, bone marrow, and function supporting framework. Means just you must have seen fish. While fishing, we use a net. It's kind of a supporting framework. Okay. And Ehlers-Danlos syndrome. Yes, correct, Rohit. Ehlers-Danlos syndrome is basically a deficiency of type 3 collagen, and this type 3 collagen actually, this Ehlers-Danlos can be of various type. I believe even the aortic ruptures can be there. The aortic ruptures can be there in this syndrome, I believe. There are different types because of those missing reticular fibers. I'm not very sure about that, but you are correct that like the deficiencies can result in that kind of pathology. But here, at coming to the topic proper, so reticular connective tissue, these fibers, short, branching, single running fibers, and these dots, what you see are lymphocytes. Okay. So they're just making a framework where the lymphocytes will be there. And now you see, these are epithelial reticular cells. Epithelial reticular cells are typically seen in thymus, and thymus do not have reticular fibers. These cells, they interconnect with each other. Gap junctions, sorry, these tight junctions are there, and using those tight junctions, they make the reticulum, and it has a purpose. So what is the purpose of thymic reticulars? And remember, embryologically, they are endodermal in origin. Thymus is endodermal in origin. Pharyngeal pouch number 3. Thymus developed from pharyngeal pouch number 3, is endodermal in origin. Thymic reticular cells are endodermal in origin, though lymphocytes are mesodermal. Lymphocytes are mesodermal, but thymus itself is endodermal. Okay, so what are they doing? These cells, they will actually make a kind of a protective layering around the lymphocyte. They will surround the lymphocyte and of course give it a home so that it can stay there and surround them and gradually expose it to the antigens. Because if a lymphocyte come and suddenly you expose the lymphocyte to the antigen, it might not understand what is this because it is something new for it, and maybe the antigen will kill the lymphocyte. So it must be trained. Thymus trains the lymphocytes for T cell mediated immunity. So what these cells do is they will surround the lymphocytes and give them gradual exposure to the antigens and train them. And in that process, actually 90% of them die. The lymphocytes die. 90% die. Only 10% lymphocytes survive in thymus. It's a tough trainer. Thymus gland is a very tough trainer, and soldiers don't survive here. 90% soldiers will die. So 10% will survive. Then they'll be stamped. Now you can go and take care of the body, your T lymphocytes, and go fight. So these epithelial reticular cells are very important. They create blood thymic barrier, you can say, or blood lymphocyte barrier, whatever. They don't let the lymphocyte expose to the antigen in the blood directly. So they will create a barrier, basically blood thymus barrier, you can say, or like that. So that is the importance. Okay. Anyway, so this was the question. Reticular fibers are absent in, and we said thymus. And here, one other thing we can do is, can you tell me where else do we have this reticular type 3 collagen fibers? Where else we have this type 3 reticular fibers? As you were mentioning, it can be in the aorta also. It can be in the GI tract, blood vessels, tunica media, especially the aorta. Ehlers-Danlos syndrome, yes, now I remembered. Some things are in our random access memory and some things are in our hard drive. This information suddenly has surfaced now. It came from my hard drive. Now I remembered. Ehlers-Danlos, you were talking about Ehlers-Danlos. So, what I'm trying to tell you is type 3 collagen fibers are there in tunica media of blood vessels, and there can be weakness of the walls and they may rupture and aortic ruptures and patient will die. So that is kind of, I'll advise you to read it from your pathology books. That will be better. Or you can ask your pathology faculty, but that is the clinical relevance. Okay, let's move further. Which structure is deeply related to the arrow mark area? Now, okay, let me just go through the chat. Let us see if I have to add something. Sir, in neuros, yeah, of course, of course, of course. See, it's a mix of FMGE and even your all the exams, INI-CET, NEET PG. But take it from me that if you are being prepared for your INI-CET FMGE, NEET PG, automatically your FMGE requirements are taken care of. So don't worry, we'll take care of all of you. Don't worry at all. And now, yeah, you trusted PrepLadder for your FMGE. Even I trust PrepLadder for FMGE. Though I am not giving FMGE exam, but I have total faith. The faculties are great. Dr. Marwa, Dr. Pritesh, Dr. Wes, Dr. Poof. नाम लो, डॉक्टर स्माइली मैम, नाम लो, किसका नाम लो बताओ। सब लोग मेहनत से बहुत अच्छा काम कर रहे हैं, बहुत अच्छा प्रोडक्ट है और बड़ी अच्छी बात, पढ़ो उतना चाहिए जितना तो इससे अच्छी और क्या बात है कि कम पढ़ के भी काम चल रहा है। वैसे मैं इसके खिलाफ हूं, मैं ज्यादा पढ़ाने वाले लोगों में से हूं, शायद मैं PrepLadder में ठीक से फिट बैठता भी नहीं, ऑड मैन आउट, लेकिन you can totally depend upon PrepLadder, and rapid revision is a great masterpiece. Yes, no doubt. Okay, so yeah, DJOR syndrome. We'll come to DJOR syndrome. We'll come to DJOR syndrome. Not second. It is third pouch problem actually. A gamma globinemia catch. Yeah, catch 22Q. Yes, you are correct, Rohit. You are correct. That is catch syndrome is there. DJOR syndrome is a catch syndrome. Yes. New scars. New scars. If you say new scars, yes, Rohit, correct. Fantastic. Yes. So type 3 collagen. Type 3 collagen can be there in granulation tissue. Granulation tissue, recently healing tissue, type 3 collagen. Yes, correct. And abdominal aortic aneurysm, Gurinder Singh, perfect. That is what I was talking about. And Tyrion. Okay, so now we are moving on to this, right? So you see this question, whoever has asked this, definitely he is a neurosurgeon doing PhD in clinoidectomy approach for suprasellar tumors. I'll repeat again. Whoever has given this question is a neurosurgeon and he is doing PhD. Just imagine, is a neurosurgeon doing PhD in clinoidectomy approach for suprasellar tumor removal. And this question is now in front of you. And tragedy is that so many of our colleagues, friends, they're just, yeah, okay, this question has come, this is the, okay, student, this is the answer, okay, let us go to the next question. I really wonder, such casual approach by the faculty is very dangerous. They're not performing their duties perfectly. Either you say, I don't know the answer, or if you take the challenge, then hold your ground strongly. And despite so much of research, even this day I'm not confident what I'm going to tell you right now. And still I keep reading things about it. And these people so casually they tell, and then, so it's not a good practice actually. But anyway, why should I comment on other people? We should be focusing more upon our things rather than others. Which structure is deeply related to aeromarket? First of all, what is this? This is H-shaped suture, the tyrion, the weakest portion of the skull, And especially if you are talking about some, accidents, road traffic accidents, some young fellow going on a bike and without helmet and falls down and hits and there is a fracture here. So H-shaped suture pterion and is the weak part of the skull, can be damaged in road traffic accidents, and just deep to that is running anterior division of middle meningeal artery. Anterior division of middle meningeal artery, which will bleed. An extradural hemorrhage or epidural hemorrhage, it is the same thing. Epidural hemorrhage or extradural hemorrhage will happen, and this fellow, immediately he will have loss of consciousness on impact, but then he regains consciousness and then he will again lose it. There will be a lucid interval. Once again, there was a road traffic accident, this fellow fell down, there's a fracture here, bleeding started, the vessel is anterior division of middle meningeal artery, the bleed is extradural hemorrhage, what is also called epidural hemorrhage. He will have loss of consciousness immediately, maybe for brief moments, and then he will wake up and he will feel, or it may not be too much troublesome for him maybe, and he will be lucid. Lucid interval will be there, means a period of consciousness between two periods of unconsciousness. So a period of consciousness between two periods of unconsciousness. Lucid interval comes in psychiatry also. This is surgery. So he will be conscious, but then second time when he loses the consciousness, then you lose him. He will die. So in that time only, you have to work upon this, take a CT scan immediately and look for the amount of blood, how much blood has come out. And you may have to put burr holes, evacuate the clot and do all those things. But the point is, here they are asking, what is deep to that? Now, what is deep to that is one artery that we already know. These questions come and everybody answering, and if everybody is answering, that question will not come again. Take it from me. Questions are not repeated like that. Questions are repeated only when you answer wrong. So they will go deeper now. They dig deep. So they have dug deeper. So what is deep to this? You have to look it from inside now. But from outside, you should know pterion is a place where side view is there, and frontal bone, posteriorly parietal bone, posterior inferior temporal bone, and this is greater wing of sphenoid. Greater wing of sphenoid. So greater wing of sphenoid, antero inferior. Posterior inferior is the temporal bone, squamous part of temporal bone. Posterior superior is parietal bone, and on the front is frontal bone. This is pterion. Now we will look upon it from inside. Here you will find, say this is the middle meningeal artery, branch of the maxillary artery coming inside, a branch is coming inside the cranial cavity. Middle meningeal artery is a branch of the first part of maxillary artery, first of all, the artery to maxilla bone. Artery to maxilla bone, maxillary artery. Maxillary artery, first part will give middle meningeal artery. Middle meningeal artery, the name is telling that it will supply meninges. So middle meningeal artery, branch of the first part of maxillary artery, is entering the cranial cavity, passing foramen spinosum. And passing the foramen spinosum in the greater wing of sphenoid at the base of the skull, at the floor, to reach the floor of middle cranial fossa. I repeat, middle meningeal artery is passing through the base of the skull through foramen spinosum and reach the floor of the middle cranial fossa through the foramen spinosum, and then give two branches. One anterior branch of middle meningeal artery, one posterior. So we don't focus on posterior, we focus on anterior. Anterior division of the middle meningeal artery or frontal branch of middle meningeal artery is passing deep to the pterion. That is why if pterion is fractured, it will bleed. And that is what we told, that there will be extradural hemorrhage or epidural hemorrhage. But that is a different story. Our question is not that. Our question is, what lies deep to that? Now, deep to that is lesser wing of sphenoid. And not exactly lesser wing of sphenoid. Examiner wanted you to understand anterior clinoid process, which is a part of lesser wing of sphenoid. So it is anterior clinoid process, which is a part of lesser wing of sphenoid. Now, anterior clinoid process, posterior clinoid process, they are making the boundary of sella turcica. Sella turcica is in the body of sphenoid to keep the pituitary gland. You want to keep the pituitary gland in the sella turcica, which is in the body of the sphenoid. It has some boundaries. Anterior clinoid process in the lesser wing of sphenoid, and this is the posterior clinoid process, which is in the body of sphenoid. So the options which were given to you were lesser wing of sphenoid, sella turcica, the posterior clinoid process, and one more thing. I believe that was a canal or something. So carotid canal is still more posterior, where carotid artery will enter. Internal carotid artery will enter carotid canal. So it will be slightly more posterior. Means if you are exactly at the pterion, deeper to that would be anterior clinoid process of lesser wing of sphenoid. So what is the importance? Importance is, I have a tumor, supracellular tumor. I want to remove it. I will do anterior clinoidectomy and deal with the tumor. So how do I reach and remove this anterior clinoid process? Via pterion, that's all. So what they do is, they will access through pterion, go deeper, cut the anterior clinoid process and deal with the tumor. That is their purpose. Everything is genuine. These questions, don't think that these are bogus question and useless and they don't serve us any purpose. No, they are all important question, but maybe we don't appreciate at this moment because we are at a very low level at the moment. But the answer should be lesser wing of sphenoid. If lesser wing of sphenoid is not there, it would be anterior clinoid process. Sella turcica cannot be because it is more posterior. And posterior clinoid process is, of course, still more posterior. Carotid canal is yet more posterior. So exactly deep, if I take a needle and a prefined needle or trocar or whatever and go straight, then I'll reach the anterior clinoid process here, straight. So lesser wing of sphenoid, that anterior clinoid process. That is the purpose of this question actually. Okay. Now, as you are proceeding further, okay, so let us move for next. And here, yeah, okay. Now, we can do one more thing. This sphenoid bone, sphenoid bone. There are a lot of questions on sphenoid bone. Sphenoid bone is like a butterfly. It is like a butterfly. It has a body, which you see here. This is the body. And it has wings, like this is lesser wing and greater wing. So it will be better seen from superior view. You ask a patient to lie supine. Say this is the cadaver. Cadaver in supine posture, this is the head towards you, feet away from you. You remove the skull cap, remove the brain of the cadaver. Look at the floor of the cranial cavity, and as you look at the floor of the cranial cavity, this blue color bone, which you see here, is the butterfly, the sphenoid. So this sphenoid will have a body of sphenoid, body of the butterfly, and this is lesser wing, which is at the floor of anterior cranial fossa on either side, and then this is the greater wing of sphenoid, which is at the floor of middle cranial fossa. So the bigger one is greater wing of sphenoid, the smaller one is lesser wing of sphenoid, and the lesser wing of sphenoid is at the floor of anterior cranial fossa. Greater wing of sphenoid is at the floor of middle cranial fossa. Between the two, you have a fissure, superior orbital fissure. You can say the fissure is between lesser wing, greater wing, and you can also say that it is a fissure between anterior cranial fossa and middle cranial fossa. And through the fissure, there are some structures to enter the orbit or leave the orbit through superior orbital fissure. The gap between lesser wing, greater wing. That is one thing. Second thing is that lesser wing has an opening, optic canal, for the passage of optic nerve. So optic canal is an opening in the lesser wing of sphenoid for the passage of optic nerve. Greater wing has some openings, like you will see foramen rotundum, round foramen, foramen ovale, oval foramen, and foramen spinosum. Foramen spinosum, we just said that there was this middle meningeal artery passing through that, foramen spinosum. What are the openings in the greater wing sphenoid? A round foramen rotundum, oval foramen ovale, and foramen spinosum. Can you see a marking here? This is the marking for the middle meningeal artery, giving anterior division and posterior division. This anterior division is going to this place. This is the H-shaped suture from inside. That is H-shaped pterion from inside, which is contributed by greater wing of sphenoid here, frontal bone from the front, parietal bone from posterior, and then the squamous part of temporal bone. You saw it from outside. Now this is from inside. That is the pterion, H-shaped suture, anterior branch of middle meningeal artery, and deep to that is lesser wing of sphenoid. Anterior clinoid process is here, but that is not the point we are focusing right now. Right now, you have to understand foramen rotundum, the maxillary nerve branch of trigeminal nerve. And when the maxillary nerve branch of trigeminal nerve is passing the foramen rotundum to supply bone maxilla, before it reaches maxilla, it will pass through one space, what is called pterygopalatine fossa, anteriorly. Once again, trigeminal nerve, maxillary branch, supplying the bone maxilla, has to pass foramen rotundum and then go anterior in pterygopalatine fossa and supply the bone maxilla. Because the name is maxillary nerve, it will supply maxilla bone. You just remember that. Now this foramen rotundum can be seen from superior view, like this is superior view, you can see that. It can be seen from the anterior view also, from the front. So this is the same story, so no need. From the front now, you see this is from the front. You are looking from the front. This is orbit on either side. And what you do, remove the nasal bone, remove the ethmoid bone so that you see the sphenoid bone now. What is the approach? Remove the nasal bone, remove the ethmoid bone, and look at the sphenoid bone. This is how you will find the sphenoid butterfly. Now this butterfly, I told you, there's a body. This is the body, which is hollow from inside. You know, it is what to say, pneumatic bone. Sphenoid bone is a pneumatic bone. It is hollow from inside to keep the skull lighter and resonance of voice and all that. Sphenoid sinus, sphenoid air sinus. I'm touching my frontal bone here. It will be deeper here, deep to the nasal area. So the body of sphenoid is hollow from inside. It is a pneumatic bone, dual purpose, make the skull lighter and resonance of voice. Okay, that is body of sphenoid. Then what is this? This is lesser wing attaching to the body on either side, and this is greater wing attaching to body on other side. It has legs also. These are the legs which come down, and the legs are called as pterygoid process. And pterygoid process also, they'll have two processes: lateral plate of pterygoid process and medial plate. And if you like, I can just add, medial pterygoid muscle, lateral pterygoid muscle take their origin from here. They are basically muscles of mastication. So medial pterygoid, lateral pterygoid take their origin from here, muscles of mastication. So just additional information, but the point here is, I told you, foramen rotundum can be seen from the front view also in the lesser wing of sphenoid. So lesser wing of sphenoid was having foramen rotundum for superior view, now front view. Now that was a question. So this is the question. Tell me. This question is the arrow marked foramen is. So you will be confused between some other things like, okay, let us say this is foramen rotundum, then what is this? What is more lateral and what is more medial? And what is this? And what is this opening here? See, this opening is in the body of sphenoid, so it doesn't matter. That is basically sphenoid air sinus and all that. So don't bother. This is superior orbital fissure between lesser wing of sphenoid and greater wing of sphenoid. But looking from the front view, you have to understand you are looking from here, front view of the eyeball socket. The lesser wing and greater wing, they form the wall of the orbit. The lesser wing is the roof of the orbit. Greater wing is the lateral wall of orbit. Body of sphenoid is the medial wall of the orbit. I repeat, If you remove the nasal bone, ethmoid bone, what you see is sphenoid bone. Contributing to orbit wall. Lesser wing will contribute to roof of orbit on other side. The greater wing will form the lateral wall of orbit. Body of sphenoid will form medial wall of the orbit. And what is this gap between lesser wing and greater wing? That is superior orbital fissure. And what are these opening then? What is this opening? What is this opening? This opening is just an aperture in the sphenoid air sinus. So don't bother about that. Nobody will be interested in that. Examiner is interested in asking you, what is this laterally and what is this medially? Now, laterally for a rotunum, of course, but medially is pterygoid canal. Pterygoid canal. You know, I told you this is a butterfly, it has a foot, so it is pterygoid process, and pterygoid process, pterygoid canal. So, pterygoid canal is medial. That is what you have to remember. This is more lateral, the foramen rotundum. The maxillary nerve will come here to enter pterygopalatine fossa. And what will be there in the superior orbital fissure? Superior orbital fissure will have some nerves, like the formula of the eyeball, LR6SO4 remainder 3. Now number 3, 4, 6. So number 3, 4, 6 for what? For controlling the muscles of the eyeball. So number 3, 4, 6, LR6SO4, 3, they can come here and they can control the muscles of eyeball. So that is the content of superior orbital fissure. Now what is the content of pterygoid canal? What is the content of pterygoid canal? Pterygoid canal has some content. One you can remember, nerve of pterygoid canal, Vidian nerve of pterygoid canal. Now, if you say it is Vidian nerve of pterygoid canal, what is this nerve and what is it for? It is sympathetic plus parasympathetic. Okay, it is sympathetic plus parasympathetic, but who contributed to it? Now you remember GDP. GDP. And what is GDP? G for greater petrosal nerve, branch of facial nerve. G for greater petrosal nerve, branch of facial nerve. And GDP, what is D for? Deep petrosal nerve coming from sympathetic plexus around internal carotid artery. I'll repeat. What is there here in pterygoid canal? The nerve of pterygoid canal, Vidian nerve of pterygoid canal. And what is special about Vidian nerve of pterygoid canal? That it is sympathetic plus parasympathetic. Where does it get its parasympathetic fiber from? Parasympathetic fiber or sympathetic fiber, remember the mnemonic GDP. G for greater petrosal nerve, branch of facial nerve giving parasympathetic fiber. And sympathetic fiber, deep petrosal nerve coming from sympathetic plexus around internal carotid artery. Okay, and what is P? P is pterygoid nerve. Okay, GDP, P is pterygoid nerve. Yes, pterygoid nerve of the pterygoid canal. Yes, Vidian nerve of pterygoid canal. Yeah, P. Okay, so greater petrosal nerve plus deep petrosal nerve will form the pterygoid nerve. Yes, you can say that. And not done now. Previously, we used to cut this nerve, Vidianectomy, cut the Vidian nerve. And why would you cut the Vidian nerve, Vidianectomy? This is the nerve coming from Vidian canal and you cut it. Vidianectomy used to be done for cases of intractable rhinorrhea. Intractable rhinorrhea. Running nose and it is not stopping. Whatever you do, it is not stopping. So you cut the nerve, it will stop because nasal secretions are controlled by Vidian nerve. Vidian nerve is controlling not only nasal secretion, it will control lacrimation and nasal secretion and palatal secretion, L and P. L and P, lacrimal, nasal, palatine secretion. So when you say pterygoid nerve is controlling lacrimal, nasal, palatine secretion and you are cutting it just because your patient is telling my nose is running, vasomotor rhinitis, and nose is running, intractable rhinorrhea, it doesn't stop, you cut the nerve. Of course, you have stopped the running nose, but then the eyes will become dry. The palate will become dry. Palate becoming dry is not a big issue, but eyes becoming dry is definitely an issue. So any patient where you do Vidianectomy, you would have to give eye drops. Eye drops. And when you give eye drops, they will come to nose also, nasolacrimal duct. So the thing is, if you have done videonectomy, then of course you have stopped running nose, but the nose is dry. Epistaxis, there will be epistaxis. You cannot keep nose dry. So how to keep the nose wet? Hemicellulose drop and all that, you give that in the eye, it will come to nose, so eye is wet and nose is also wet. So there are side effects, you have to take care of them. Post videonectomy, you must prescribe hemicellulose, eye drops and all that. So just going a bit off track, but it will make you remember the thing. That is the purpose. So aromatic foramen is no problem. This is foramen rotundum and round foramen, and through that maxillary nerve is coming. Okay. Now these kind of questions are coming very frequently, though very repeated. Okay, so Rohit is asking foramen ovale, male structures pass. Yes. So Rohit, male structure, M for mandibular branch of trigeminal, and A for accessory meningeal artery, and L for lesser petrosal nerve, and E for emissary veins. So foramen ovale, male structure pass, correct, in male and female both, of course. And M for mandibular nerve branch of trigeminal, A for accessory meningeal artery, L for lesser petrosal nerve, which carry preganglionic fiber to parotid salivary gland, lesser petrosal nerve, and E for emissary veins connecting extracranial, intracranial venous system. So that is perfect. And one day to go. Where? Lucknow. Yeah, I'm coming to Lucknow. Yes. Okay. Right. So we come here, and which of the following? Let me just see what is time. Oh, 6:57. When did we start? 5, 6, 6:57. I'm the only person, I believe, who overshoots his time limits, and people get bugged up that what is wrong with this person. Let me just orient myself. Say we started at 5, isn't it? 6, 7. So 2 hours are already passed. Foramen ovale, male structure, mandibular nerve, accessory meningeal. Yes, correct. I think this should be the last thing we have to discuss, because cannot overshoot too much. Otherwise, it defeats the purpose. So let us take care of this question also. Which of the following marked nerves are associated with ocular movement? Actually, it is the formula LR6, SO4, remainder 3. LR6, lateral rectus supplied by 6th nerve, abducens nerve, and LR6, SO4, superior oblique supplied by 4th nerve, trochlear nerve, and remainder 3 means rest all skeletal muscles supplied by 3rd nerve, oculomotor nerve. So nerve number 3, 4, 6. So you have to look for nerve number 3, 4, 6. Now, I don't know like which nerve is where, so we have to first find out where is the number 3, 4, 6. For that purpose, you let the person lie again supine, head is towards you, feet away from you, and open the skull, remove the brain, look at the floor of cranial cavity, which is anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. And then you see that at the floor of anterior cranial fossa, at the roof of nasal cavity are passing axons of cranial nerve number 1, olfactory nerve. So olfactory nerve, cranial number 1 for smell pathway, axons pass scripiform plate of ethmoid bone and near the midline at the floor of anterior cranial fossa. Now, lesser wing or sphenoid has one opening, that is optic canal for the passage of optic nerve, which is bringing visual information from the eyeball in the orbit. So this is the number 2. The number 3, the number 4, the number 6 are the one which will supply the eyeball muscles. Now be careful here, please. Simple thing. The number 2 and 3 are together, and the number 4 and 5 are together. In the middle, you will see 6th nerve. So don't confuse calling it as 4th nerve. Be careful again. The number 2 and 3 are together. The number 4 and 5 are together. So the one which is here is 6th nerve. can be identified by one more fact. Sixth nerve can be identified by one more fact, which I'll mention, but before that. So this is the number 2, this is the number 3, this is pituitary fossa, the sella turcica, the posterior clinoid process here, anterior clinoid process here. That is where you get to keep pituitary gland. This is lateral to that will be cavernous sinus. These some of nerves are becoming content of cavernous sinus. Now, nerve number 3 supply most of the eyeball muscle, yes. Nerve number 4 is thinnest cranial nerve and smallest cranial nerve because it has very few axons. Supply only superior oblique muscle. So trochlear nerve, 4th nerve, is thinnest cranial nerve, smallest cranial nerve, having very few axons, controlling only one muscle, superior oblique muscle. Whereas trigeminal nerve is the thickest cranial nerve, trigeminal, 3 nerves into 1. Trigeminal, lot of axons, thickest cranial nerve, and largest also. So largest means size, thickest, size. So largest and smallest nerve, they are together. Smallest and thinnest nerve is trochlear, and trigeminal is thickest and largest. Okay. Then what about the 6th nerve? 6th nerve, first of all, is actually piercing dura mater at the floor of posterior cranial fossa, near the midline. This is the most medial nerve here. So most medial nerve here, 6th nerve, and piercing the dura mater at the floor of the posterior cranial fossa, passing the Dorello's canal. Before it enters the cavernous sinus. Before it enters cavernous sinus, passes the Dorello's canal. And abducent nerve, though it may appear running like in the middle, and you may be confusing, like you might say, this is the number 2, 3, 4. It is not 4, it is 6. Why? Where is 4? 4 is here. Here also, if you look at this is 2, and this is 3, but this is 6, and then this is 4, and then this is 5. So 4 and 5 are together, 2 and 3 are together. In the middle, what you see is the number 6. So be careful about all that. Okay. Okay, now we have seen the first 6 nerve. What about the next 6 nerve? They are in the posterior cranial fossa. Yeah, in the posterior cranial fossa, where are they? The number 7 and 8 pass internal auditory meatus to enter petrous temporal bone. The number 7 and 8 in the posterior cranial fossa pass internal auditory meatus to enter petrous temporal bone. The number 9, 10, 11 are passing in the jugular foramen. A foramen which is between temporal and occipital bone. These type of questions are coming now. So where is jugular foramen? Between 2 bones. Which 2 bones? Temporal bone and occipital bone. So between temporal and occipital bone, there is jugular foramen having jugular vein. The jugular vein? Internal jugular vein. What is the purpose of internal jugular vein? Drain the brain. So you drain the brain into internal jugular vein, and it is passing through the jugular foramen along with nerve number 9, 10, 11. Now 9, 10, 11 nerves, they are passing here. 9th nerve has a separate dural sheath. 10, 11 are going in a common sheath. All of these are MCQs. I repeat things again. First of all, where is jugular foramen? It is between 2 bones, the temporal bone and occipital bone. And what is passing there? Internal jugular vein with nerve number 9, 10, 11. What is the purpose of internal jugular vein? Brain drain into internal jugular vein. Internal jugular vein will drain into the heart via some other channels, but towards the heart, it carries blood towards the heart. Okay. So what about nerve number 9, 10, 11? 9th nerve has a separate dural sheath, whereas the 10 and 11 have a common dural sheath. That came as a question. Okay, so you told this is 7, 8, 9, 10, 11. Where is 12? 12th nerve is called hypoglossal nerve, passing hypoglossal canal in the occipital bone. So 12th nerve is hypoglossal nerve, passing hypoglossal canal in the occipital bone. What is this thing here down there? That is spinal cord. Giving spinal accessory nerve, which will enter and exit the cranial cavity now. This is spinal cord, which is giving spinal accessory nerve, which will enter and exit the cranial cavity. Why? Because spinal cord, when it gives the nerve, it has to enter cranial cavity, passing foramen magnum, and then exit the cranial cavity, passing jugular foramen. It will take a U-turn, stay in the cranial cavity for a short distance, and then exit cranial cavity again. And what does it do? It will supply trapezius and sternocleidomastoid muscle. Trapezius and sternocleidomastoid muscle, that is the function of spinal axillary nerve. Now, you see spinal cord here, but it is in vertebral canal, not the foramen magnum. Be careful. In the foramen magnum, you don't have spinal cord. Spinal cord is in the vertebral canal, which is inferior. Then what is in the foramen magnum? In the foramen magnum, you have lower part of brainstem, or you can say medulla oblongata. So medulla oblongata is there in the foramen magnum. Of course, it will continue downward as spinal cord, but spinal cord is not in the medulla oblongata. And spinal cord is in the vertebral canal, slightly inferior. Okay, so this was one information we wanted to have. Now, let us try to correlate the information which we have secured. See, this is a superior view of the cranial cavity. We have removed the skull cap, brain, and looking at the floor of cranial cavity. Anterior cranial fossa, middle cranial fossa, posterior cranial fossa, cribriform plate of ethmoid bone, cranial number 1. And this is optic nerve in relation to this internal carotid artery, which is on the side of pituitary gland in the sella turcica. So midline is the pituitary gland, and on the side is internal carotid artery on the other side. Anterior to that, this area is optic nerve, passing the optic canal in the lesser wing of the sphenoid. Okay, this is the nerve 2. Yes, the number 1, the number 2. This is the number 3. Quite easy to find, in fact. Difficulty comes with number 4 because number 4 is so thin, thinnest cranial nerve, smallest cranial nerve, that it has just very fine few axons. So this is the number 4 on this side, number 4 on this side. And then I told you the number 2 and 3 together, the number 4 and 5 together. This is 5, the thickest cranial nerve. On this side, on that side, so that is thickest cranial nerve, that is the trigeminal nerve, 4 nerve, 5th nerve, where is 6th nerve? 6th nerve near the midline and piercing the neurometer at the floor of posterior cranial fossa. Be careful, posterior cranial fossa is a typical thing here because all of them are not related as such to posterior cranial fossa. 6th is, and then it will pass through Dorlius canal and then enter the cavernous sinus. Okay, so you have seen the 6 nerves, the first 6 nerves, the next 6 nerves. They are the number 7, 8, passing internal auditory meatus to enter the petrous temporal bone, and the number 9, 10, 11, they are passing in the jugular foramen. Now, maybe it is evident or not evident to you, but the number 9 is more anterior and is running alone in a single dural sheath, whereas the number 10, 11, they will have a common dural sheath. So the number 9 run in a isolated dural sheath of its own and run more anterior compared with the number 10, 11. This is spinal axillary nerve coming from the spinal cord from below. It has already passed the foramen magnum and then it has entered the cranial cavity, then going to come out of the jugular foramen and supply sternomastoid and trapezius. Where is 12th nerve? 12th nerve is hypoglossal nerve in the hypoglossal canal, and you may find that C1 fiber coming from spinal cord are also coming here. Again, 12th nerve, hypoglossal nerve, is passing hypoglossal canal in occipital bone, is joined by C1 fiber from spinal cord. The 12th nerve carries cervical 1 fibers to supply some strap muscles in the anterior neck. In the anterior neck, there are 2 strap muscles which are to be supplied by C1 fibers, but C1 fibers themselves cannot come there, so they follow the 12th nerve. C1 fiber means cervical spinal cord basically. So this is some of the information which want to know, and you can come back now here. I think our answer should be evident. Which of the following marked nerves are associated with ocular movement? Ocular movement. Now, number 3, 4, 6. Okay, now number 3, 4, 6. Let me see. What is marker A? Marker A is optic nerve, and marker B. Marker B is oculomotor nerve, and marker C A is trochlear nerve and marker D, the trigeminal nerve. So B and C, yes, B and C, 3 and 4, B and C. That is our answer because there is no marker on the abducens nerve. So like that, what I train my student is not only my job is to give you information, authentic information, but also how to tackle the exam questions because these are strategic exams. You must learn how to tackle the questions. Okay. So please tell us important concept or topics for FMGE. Now, see, what should I tell you? See, I, uh, I'm a teacher. Don't want to sound like a businessman, but the rapid revision which is there in PrepLadder is having all the important topics for your FMGE if you wish to go for that, and if not, you have books by Dr. Marwa sir, FMGE, last 5-year MCQs you have to deal. They are the important topics. Or if none of that, just go to Google, go to YouTube, Dr. Rajesh Kaushal, FMGE. Dr. Rajesh Kaushal, FMGE. I am discussing all the important topics for your FMGE. Increase the speed to into 2 because I speak usually slow, and keep watching. They are the important topics. Okay. Sir, I'll be having only 1 month to revise 19 subjects for a second time. How should we approach it? Because I'm getting 1 or 2 days each subject for FMGE. Again, the same story. Last 5-year MCQs. Practice them again and again. That is the only best approach I can tell you. The best approach to study anatomy, I already displayed it. This is the best approach. Pick a question, take the topic, strengthen the topic, practice more MCQs. This is how you, and related clinically. That is how you do anatomy. And 6th is longest intradural course. Correct, very correct, because it has punctured the durameter quite early in its course. The abducens nerve has longest intradural course. Correct. Nafu, that is correct. And Kajal is asking conceptual topic for FMG. Kajal, same thing as I mentioned. Last 5-year questions, and a lot of them are already on YouTube. Rapid revision in PrepLadder is a good thing. If you wish to use Dr. Marwa sir's compilation of last year FMGE papers are good. You have another author also, Dr. Kamal KB. You can go for that as well, I believe. But Marwa sir's explanations, I feel they are they're good basically. Both books are good, no issues as such. And स्टार्ट हुआ तब 300 स्टूडेंट थे, अब 110 बच्चे। हाँ तो भाई सुनो मेरी बात, सिलेक्शन कितनों का होगा, यही तो है। 100 में से सिलेक्शन कितना का होता है? 10 का होता है ना। बर्दाश्त जिसकी होगी उसी का ही होगा। ये तुमने लिखा है ना यहाँ पर कि 300 थे और 110 बचे। 110 वो बचे जो झेल रहे हैं मुझे, और सिलेक्शन भी उनका ही होगा। तो चले गए वो चले गए। देखो भाई ऐसा है, तपस्या है ये। अब मुझे कोई फर्क नहीं पड़ता, मैं सच बताऊं, शुरू में मुझे लगता था, थोड़ा महसूस होता था, मुझे कोई फर्क नहीं पड़ता। देखो 2 बच्चे भी, मैं तो खाली दीवारों को पढ़ा देता हूं लेकिन पढ़ाऊंगा ऐसे दमदार के, मतलब जब तुम एग्जाम दोगे ना तो तुम्हें मजा आएगा, याद करोगे। वो है तरीका मेरा। बाकी बच्चे तो भाग ही जाते हैं मुझसे, खड़ूस बुड्ढा पता नहीं क्या बोल रहे हैं। तो काफी मैं पसंद नहीं हूं, लोगों को नापसंद हूं, लेकिन मैं अपने पर्पस को कभी नहीं भूलता, और आपको भी नहीं भूलना चाहिए। हमारा पर्पस एक ही है, आपको जल्दी से जल्दी ये बैरियर क्रॉस करना है। FMGE है तो 50% मार्क्स से ज्यादा लेके आओ, और PG है तो PG लो और जिंदगी जीना शुरू करो। जिंदगी अटक गई है आप लोगों की, राइट। एक बार जी हाँ, बिल्कुल। थैंक यू वेरी मच। आप नमस्ते कर रहे हैं, मैं भी नमस्ते कर रहा हूँ। आपका बहुत बहुत शुक्रिया। यू इट्स यू पीपल, यू स्टूडेंट्स हु गिव अस अपॉर्चुनिटी टू सर्व यू, and we try our best, work very hard, and our purpose is dual. Number one, make you good physician, good surgeon, and number two, make you good humans as well. So all the best, take care, and may you achieve your desired targets as early as possible. Thank you.